If I can't penetrate deep enough, then I will go to a lower frequency and consider a curvilinear transducer. But I'm going to start with this one, which is a 214. So it goes up to 14 megahertz. We'll see what I can do with this. The gel is really cold. So what I'm going to do is put the transducer along the femoral neck, which is going to be kind of the sagittal oblique plane. You ready?
Yep.
Here we go. So the transducer is going to be turned like this along the femoral neck. And what I want to do is look for the bone landmarks of the femoral head and neck. Distal will be to the right. So I'm going to increase my depth. And you can see right there is the femoral head. Here we go. Here's the acetabulum, the femoral head. Now remember, when we're looking for a joint effusion, we're going to focus over the femoral neck, which is right here. You can appreciate the tissue here, which is the joint capsule that's reflected on itself. But this is where I'll look for fluid. This is where I'll put my needle if I were injecting or aspirating the hip joint. Now, the pitfall here would be if I'm not perpendicular to the femoral neck, you can see I want that neck to be perpendicular, to be bright, so that the capsule looks bright. If I were, let's say, like this, oblique, let's say I'd lower the gain, it can almost look like fluid. So remember, you're allowed up to about 4 millimeters or double this thickness. So don't look at this and mistake this for fluid. You avoid that, of course, by understanding the anatomy, but if you put pressure here to make it perpendicular, turn the gain up, you can see that indeed it's fibrillar, and that's the capsule. So that's where I'm looking for fluid or synovitis. Then move more superiorly, we can see the anterior labrum. Now, ultrasound is not great at looking at the labrum because we can't see all the areas, and our accuracy is not that high. However, the most common location for labral tear is anteriorly. So I will look at this routinely. Of course, if it looks unusual, I may go on to an MR to confirm. Remember that labral tears are very common as we age. A rule of thumb is every decade of your life is the percentage of labral tears in the population. So a 50-year-old, 50% of people are going to have labral tear. Many of them are completely asymptomatic. So it's all in the context of the clinical examination and the relevance of a labral tear, if you see it. Note that the normal fibrocartilage of the labrum is echogenic. A tear would be a hypoechoic cleft, and I'll show that in my lecture in just a moment. Another point I want to make is when looking at the joint capsule, we have to pay attention to how the leg is positioned. Most people, when they are laying on a bed, their leg somewhat externally rotates, which is what I see here. But look what happens if I internally rotate the leg. You can see that the capsule bunches up, and if, let's say, you do rely on a measurement, which I do not, that is now more than 4 millimeters. It's all bunched up. Now, if the leg externally rotated, it flattens out. So if you're looking at the joint recess and you think it's distended and you're not quite sure if it's the capsule that's redundant or fluid, look down and make sure that the leg is externally rotated, and that should flatten out any redundancy in the capsule. So then the next thing I'm going to do to finish anteriorly is I'm going to center over the femoral head and turn 90 degrees like this. So I'm not transverse on the body, I'm 90 degrees to what I'm looking at is the iliopsoas complex. So medial will be to the right, lateral to the left. Here's the femoral nerve, artery, vein, and over here we have the empty space in lymphatics. But I'm looking more lateral. I'm going to move the transducer more superiorly until I see the continuous bone contour of the ilium. At this point is where I see the psoas major tendon, the psoas major muscle, the medial part of the iliacus, the lateral part of the iliacus, the direct head of the rectus femoris. So this is where all the anatomy is located. Now, to look for snapping iliopsoas, this is where I will assess this dynamically. I'll be paying attention to the psoas major tendon sitting here on top of the ilium. So let me show you how I would assess for snapping iliopsoas. I would only do this if this was clinically relevant. I wouldn't do this in every patient, but what I would do is have the patient bend at the hip, and when the hip is bent, I'm going to toggle the transducer to make sure I have the tendon in view. I'll then have the knee fall to the side, make sure everything is in view, and then the last thing I'll do is ask the patient to stretch the leg back out. There was a little tiny snap there. I'll try to bring that out again. So normally the tendon should just slide or glides like minimally, and look what happens here. Go ahead and straighten the hip out. It didn't happen. Let's try that again. All right. Bring it out like that, and I'll straighten the hip. A little. So his iliopsoas is minimally snapping, and it's intermittent, and it's really not a big deal, right?
No.
No, it's just minimal. And how often do you feel it snapping?
If I don't do leg day, it gets worse.
If you don't do leg day?
Yes.
I'm not quite sure what leg day means. I have sit day every day.
More sit day, more snap.
So if you're not doing leg day,
Yes.
you'll feel it snapping. And when do you feel it snapping?
At night, typically.
At night?
Yeah.
Like when you're
Laying in bed.
laying in bed, just by moving your hip around?
By doing that move.
By doing that move,
Yep.
okay. So as I'm discussing here, a lot of people have minimal snapping or intermittent. It really is not a big deal. But if it's really a big deal, what I've done in the past, if I've put a needle into the area from a lateral approach and put the needle right here and injected the iliopsoas bursa with steroids. The idea is if it's snapping a lot, there might be some inflammation in the area, and that has relieved symptoms. I've had uncommonly patients go on to a partial iliopsoas release to treat it, but most of the time it's steroid injection and physical therapy in my experience. All right, so that's the anterior hip. What I'm going to do now is go on to, let me get a towel, go on to the lateral hip. Again, those are the two parts I scan in everyone. Maybe today will be my leg day. What do you think? Probably not. All right, so the idea here is the femur is going this way. I want the transducer short axis to the femur. The leg can be straight or slightly bent, it doesn't matter. I'm going to put the transducer right on the lateral part of the hip. Now what I want to do is identify the ridge of bone that separates the anterior and lateral facets. Now first of all, anterior will be on the right side of the image, over here. I'm going to decrease my depth. Well, let me talk about how I optimize the ultrasound image. I'll do that for a second. So when I put the transducer down, the first thing I do is assess my interest point and where it is on the image. You can see almost a third of this image is unused space. So what I'm going to do is, first thing I'm going to do is change the depth and get my area of interest centered on the image. That's step number one. Step number two of 3 steps is paying attention to the focal zone with this little caret here, or arrow. Not every machine has focal zones that you can move. Some of them will move when you change the depth. But this one I can change. You can see the focal zone is going up and down. And what that will do is optimize the resolution at that level. I'm interested here, so this is lined up where I would like it. If it were up here, then you can see that this might be a little more indistinct or blurry. As I come down, it looks more detailed. The third thing I do, step 3, is adjust the grayscale. There are 2 different ways of just understanding how bright the image should be. What I tend to use is the muscle as my intrinsic standard. You adjust the grayscale depending on the ambient light. The brighter your room, the brighter the image is going to have to be to see what's going on. But what I'd like to do is for the muscle is identify hypoechoic muscle tissue and bright echogenic fibroadipose layers. I don't want the image like this, where it almost looks like fluid. It's so dark. And of course, I don't want it like this, where I can't make the distinction between the muscle and the fibroadipose layers quite well. So I really would optimize it perhaps like this. So muscle is a good way to, I guess, set the grayscale so that you're not too bright or dark. Okay, back to the hip here. As I look at the bone contour, I identify here this apex of bone that looks like the roof of a house. If I'm too far inferior, the bone is round. That's the femoral shaft. If I'm too far superiorly, there's no bone because I'm above the greater trochanter. So I'm basically moving the transducer like this to find that apex of bone. A lot of times I have to go slightly anterior to see that. I would say that I would use that as my landmark. That's my home base. So the first thing I'm going to do is look for any bursitis. It's really uncommon. I'll talk about that in a moment. So what I'm going to do first is look between the gluteus medius and the bone for the subgluteus minimus bursa. I don't see it. I'll then move over the lateral facet, looking between the gluteus medius and the bone for the subgluteus medius bursa. Nothing there. And then importantly, look how far back I take this transducer. I come over like this. I'm really coming from the back of the hip because what I want to do is look between the gluteus maximus and the rounded posterior facet for the trochanteric or subgluteus maximus bursa, which I don't see. If you don't come all the way back like this, you can miss a bursal distension that occurs posteriorly. So that's really step one. After finding my home base, I'm going to look over the anterior, lateral, and posterior facets for bursitis. Now I'm going to look at the tendons. I'm going to come back to my home base. There's that apex of bone. So I'm going to look long axis now at the gluteus minimus. Now I don't turn on this long axis at this point because the tendon is relatively hypoechoic from anisotropy. What I want to do is bring the transducer anteriorly like this so that the bone turns bright and the tendon will be bright. Let me do that again. Find my home base again. There it is. So I'm going to come forward, and now the tendon is going to be right here. So I want the bone to be somewhat flat so I can see the tendon nicely right here before turning long axis. So I'm really coming from an anterior approach like this. So now I'm going to turn long axis on the tendon. Proximal will be on the left. And I'm going to angle slightly anterior like this. And here we can see the anterior facet, the gluteus medius, gluteus minimus muscle and tendon. Here's the tendon attaching. Seen better like this. Remember, the large muscle sitting on top of the gluteus minimus muscle and tendon is the gluteus medius muscle. And I'm going to try to get that a little bit more perpendicular, and there we can see the normal tendon. So now I'm going to move to the gluteus medius. I'm going to come back to my home base. I'm going to find that apex of the greater trochanter, and now I'm going to center on the lateral facet. I'm going to move the transducer posteriorly a little bit like this, and now you can see the tendon of the gluteus medius here. This is the iliotibial tractor band sitting on top. So now I'm going to move up a little bit so I have the muscle and tendon in view of the gluteus medius and turn long axis like this. And note that I'm also pointing somewhat anterior because this overlaps the gluteus minimus. So here the gluteus minimus is still down here, but now I'm focused on the gluteus medius muscle and tendon at the lateral facet. Here's the iliotibial tractor band coming over the top. Remember, the gluteus medius has two bands, so I'm only looking so far at the one attaching to the lateral facet. So to look at the more posterior superior one, I'm going to come back to my home base like this, find my apex. What I'm going to do now is come over the posterior facet, and I'm simply going to move the transducer all the way up until the bone disappears. Because I know that that other band of the gluteus medius attaches quite posteriorly at the superior posterior facet. I'm now going to turn long axis like this, and when I look at the posterior part of the greater trochanter, which is right here, This is the tendon of the gluteus medius, that other band, the superior posterior facet attachment. So that's my screening of the greater trochanter. The key is the bone landmark for the home base, look for bursa, and then go over each of these facets, turn long axis, look for tendinosis. So now I'm going to focus on the posterior facet. Here's another one. Sorry, the posterior hip. If you can roll onto your stomach. You know the routine. Okay. So when you say leg day, is it right or left? Which one?
Let's switch it up. Each day's
I'm a little naive with this whole thing. All right. So let me just do this, do this. All right. So when looking at the hamstrings, there are two starting points. You could start at the gluteal fold or at the ischial tuberosity. As a radiologist, where I don't clinically examine patients, I'm more comfortable finding the gluteal fold. You can see it in everyone. You can palpate the ischial tuberosity, but there are some patients where I'm like, where the heck is this bone landmark? So I will tend to start at gluteal fold. But I'll show you both ways of looking for it. One important reason to start at the gluteal fold is that if you completely tear off your hamstring tendons and you're looking for it proximally, there's nothing there. So you really have to understand how to get at the structures at different approaches. All right, gluteal fold. What I find is that if you simply put the transducer in the center of the posterior thigh, like this, media will be on the right, like this. And when it's right in the middle of the thigh there, what I'm going to do is toggle the transducer somewhat aggressively like this. And let me explain why this is so important. Because I'm trying to find what I call the hamstring triangle, these three bright structures. The semimembranosus, medial is over here, the conjoint tendon here, and the sciatic nerve, 1, 2, 3. If I am not perpendicular to these structures, let's say I'm like this, you can't see any of them. So when I'm training my fellows and I see this image and they're like, I don't know where I'm at, it's like, just put the transducer down in the center, and when you toggle like this, you can see the semimembranosus going from bright to dark. You can see the conjoint tendon going from bright to dark, and the connective tissue elements of the sciatic nerve going from bright to dark. 1, 2, 3. Now I have my hamstring triangle in view. We know that the muscle, the prominent one here sitting on top of the semimembranosus, is the semitendinosus. That's why that tendon is forming the conjoint tendon. Over here we have the long head of the biceps femoris also forming that tendon. This is the semimembranosus tendon, and aponeurosis coming this way. The muscle is starting to form out here. But this is my starting point. So what I'm now going to do is move the transducer superiorly. And as I move superiorly, we're going to watch the semimembranosus tendon move laterally underneath the conjoint tendon. So as I inch my way up, you're going to see semimembranosus tendon, conjoint tendon. Toggling is helping me find things. Semimembranosus conjoined. Right here. Now they're actually lined up for just a brief moment as the semimembranosus crisscrosses underneath the conjoint tendon. As we keep coming up, we're now almost to the ischial tuberosity, and there's the ischial tuberosity. So what sits here is the conjoint tendon. What sits here is the semimembranosus. So these are the two tendons. As I go distally, again, you'll see the semimembranosus here, 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 there, and then go back medial. If I go superiorly, it's going to come back, crisscrossing underneath, underneath, and then there is the attachment. Now, they look hypoechoic. They always do. In fact, over the age of 40, on MRI, everyone has a little bit of subclinical tendinosis bilaterally. So that's why it's hard to make it completely echogenic. But the other thing is, I'm not really hitting this at perpendicular. So what I'm going to do is I'm going to move the transducer laterally and point back to midline like that. And as I toggle, you can see the tendons now becoming brighter as I hit the bone at perpendicular. So this is the conjoined tendon of the biceps femoris long head and semitendinosus. Here's semimembranosus and sciatic nerve. So the other way of finding the hamstrings, other than going with the gluteal fold and toggling for the hamstring triangle, you can palpate the ischial tuberosity, simply put the transducer on that ischial tuberosity, knowing that around 11 o'clock here on the clock face is the conjoined tendon, around 10 o'clock is going to be the semimembranosus. Now what I can do now is turn long axis on these tendons. I'm going to do this. This will be to the right. At the very top of the slope is the conjoined tendon here. As I slide down the slope, we're going to go from the conjoined tendon to the semimembranosus. And as I mentioned, on these long axis views, they really look the same. I can't tell which is which. But knowing in space that I've slid down from the top of the ischial tuberosity further down, I've ventured in from one to the other. But of course, looking short axis will tell me if you have pathology, which one we're looking at. So the last thing I'll do, I think I'll stop there because I've covered the important things. Anterior and lateral, I covered posterior. The medial part is really driven by symptoms and history, and that's basically looking for a muscle tear. Plus, I'll spare Casey looking at the symphysis pubis for the morning. Okay?
Save that for tonight.